Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman. On this show, you'll receive powerful insights and resources for rural surgeons. I'm a general surgeon in Northwest Indiana, and this show is tailored around the nuts and bolts of rural general surgery practice. But you'll find topics ranging from practical surgical tips to a host of others, including rural lifestyle, finance, training, practice models, and more. We'll have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. Whether you're a surgeon, other specialist, or primary care, or simply someone interested in healthcare for rural America, I'm glad you're here. Now let's get into the show. Hey everybody, welcome back to the Rural American Surgeon Podcast. I'm your host, Randy Lehman. I've got a guest with me today, which is Dr. Ben Mundell. He is a general surgeon, just finished residency about 4 months ago, and just started his new job as a rural surgeon in the Eastern Sierras. Ben, thank you for taking the time and joining us today.
Thanks, Randy.
I've got your quote of the day, which I'd like to start. I really want this podcast to be inspirational for my guests. And today, first quote of the day, I don't know where it came from, but is passion is the dream you hold so dearly, you're embarrassed to say it out loud. This podcast is part of that for me, my whole practice. You know, it's so deeply part of my being, and I just want rural surgery to be successful for you, for me, for Ben, for the patients, for the communities, and so it's something that I really just care about. You have to have something that you're passionate about, and that gets you up, and it certainly is inspiring for me to just get to meet and talk with people like Ben to help to kind of grow this community so that we don't become so professionally isolated, and we can fight that because when you're out there, man, you're in the thick of it, and sometimes you can feel, like you're on your own, and you sort of are. So with that, let's introduce Ben. So Ben, I know from training, he is a Mayo product. So we met at the Rochester, Minnesota Mayo Clinic, and before he came into residency, he was actually a vet. So thank you very much for your service. He flew jets for the Air Force for 7 years after college, and then went back to medical school and on to residency, and did his first 3 years at Mayo Rochester, finished up his last 2 years at Mayo Arizona, and now he just landed 2 months ago in the Eastern Sierras in California, and he's joined two other surgeons in a 3-surgeon practice in a critical access hospital. So thank you, Ben, and we welcome you. I'd like to talk first about your opportunities that you have there. So tell us a little bit about this hospital that you found yourself in.
Yeah, so it's in Mammoth Lakes, California, which is right in the center of the Eastern Sierras. It's a great hospital from a leadership standpoint, really financially stable. We have the benefit of having a major ski resort in town, so that generates a lot of trauma in the winter, from what I'm told, and a lot of visits in the summer too. And we're about 20 miles from the eastern entrance to Yosemite, so we have a lot of heavy tourist industry. So town about 8,000, and it grows probably to 35,000 at least on the weekends. And so then, a lot of the other hospitals in the Eastern Sierras haven't been doing as well. So they've, closed down or found financial trouble not having the surgical services. So we kind of serve as a referral center too for everything, a couple hours north to a couple hours south, because the closest place to us is Reno. It's about 3 hours north. Vegas is about 5 hours from us, and Los Angeles, Southern California, is about 6 hours.
Yeah. Do you think that the places that have closed, they haven't had surgery, and that's part of the reason why they weren't able to stay viable?
Yeah, and I think that some of the areas are kind of hard to recruit for, and then I think they've had just or relied only on locums. I think has been part of what I've been told, and not had reliable, consistent surgical services. We also have the benefit of having a really great orthopedics group here too, which probably about 10 years ago sort of saw a vision of kind of expanding elective care and not just doing trauma stuff. So we're trying to follow suit on the general surgery side and sort of capture more of the patients that they've been seeing, or that same population from farther away, 2-3 hours out, that don't want to go to the bigger cities, but Mammoth is a reasonable place for them to come to.
Sure. So I trained in the Mayo Rural Surgery track, and I sort of self-identified. I wanted to go back home to my hometown in Indiana, and I sought out that training. Now, you are just in the basic general surgery track, and people in Mayo can go a lot of different directions, but most people go hyper-specialized city practice. I don't just do breast surgery. I only do left breast surgery, like it's crazy. So, but for you, how did you find yourself going to rural surgery out of a ivory tower type training?
Yeah, no, that's a great question. So I think even in med school, I knew that I wanted to probably be in a smaller practice, at least a community setting, town of 100,000 or less, and possibly rural. I did a family med rotation in med school out in the health system, and the family med doc out there, he did, colonoscopies, EGDs, a little bit of everything. He even sort of ran his own little urgent care out of his family med clinic. I didn't want to do family med per se, but I wanted to be sort of in a place where I was able to use, the full breadth of my training. And Dr. Stulak was our program director at the time, was also the clerkship director. And, he said, go either way, the rural track or the basic track, either of them are good. But, I think, coming out of Mayo Med School, I sort of got pushed a little bit to not do the rural track for whatever reason, but picked up a few of those rotations while I was in residency. I really enjoyed them and knew that after doing those, that was what I wanted to do. It was to be a community or rural general surgeon.
How far into your training did you identify this place in Mammoth that you're going to?
Yeah, so I didn't find this until the end of fourth year, beginning of fifth year. So that's sort of when I really started looking for jobs. My wife's a dermatologist, so we wanted to, obviously find jobs for both of us. And we have a family here on the West Coast. So we started looking, up and down the West Coast in places that we thought would be reasonable for our family and close to family. And as it happens, my brother-in-law is one of the orthopedic surgeons here on staff at the hospital. So it was a good way to be close to family.
Yeah, that's the way. Often there's some specific draw, a spouse drawing you to a specific area. I just want to say I'm very proud of you for going to this location and to just the role that you're filling. It's very important and crucial, it's for so many levels. Like I've talked about this before on the podcast, but basically the one-to-one patient-doctor relationship drives us, and we love it. But when you're a rural surgeon, it's more than that. You're not just a commodity of a surgeon just producing, whatever gallbladder hernia surgery that you're doing. You're part of keeping that hospital viable so that people can actually have a hospital to be admitted to. It extends much further than just the case you're doing right there. And you're creating jobs for the community. You're enhancing the rural place. And people that live in rural America, believe it or not, are choosing to live there. They want to live there. It's not that they can't move to the city. I was driving today through rural Wisconsin, and I was just thinking to myself, man, how can I don't understand how somebody would want to live in like one of the three big cities in the United States. There's so much green and creation and, just the nature around that, you're in a beautiful area. I'm going to have to get out there to Mammoth and go skiing. It sounds like.
Yeah, for sure.
But I'm proud of you for what you're doing. So keep it up. And so Ben reached out to me and he just said, hey, I know you're 4 years out into a rural practice. I have opportunities here at this new place, and I'd like to talk to you about how I could make this a success. What pearls do you have, pitfalls to avoid, and whatnot. So I said, if you have those questions, I'm sure there's a resident or young attending somewhere else that would maybe have it. Maybe they'll be able to find us. Why don't we record it? So again, appreciate you coming on. So why don't I lead off maybe with a little bit of what I've done, and then you ask whatever questions you need to get the information you need to know for your practice. But basically, I started as a W-2 employee at a critical access hospital in Northwest Indiana 4 years ago in 2020. I took that job. I actually signed a contract my second year of residency, and I knew that there were loan repayment options that you could do. And I had student loans from medical school only, but I did want to get them paid off as soon as possible. So I signed that contract. I took essentially a loan from the hospital that was paid to me monthly over a period of time, and I paid all my loans off by the time I was done with residency. Then I owed the hospital 4 years of service, and that was forgiven basically on each paycheck for the next 4 years. I paid taxes on that as if it was income during that time. But that also means I got essentially 4 years of free use of the money by taking it as a loan. And the other thing is I would encourage somebody to take a deal like that if they were a young resident, because there's options. Even if it didn't work out at that place, something changed, there would be, I think, another hospital, especially if it was a rural hospital, that would buy you out of that. So, you can get the use of the money. And then if you did it, it was up to me to actually pay my loans down. But I did. I did pay my loans down because I could have spent that money. That would be a bad mistake. So don't do that. But if you can get some advanced payment and make a commitment to a place. The other thing that it helped me do is from second year on, that's why I asked when you identified to this place. From second year on, I always envisioned myself in that hospital doing the surgery that I was going to do, which really helped me with my mental part of my training, drilling it in. I remember being on vascular surgery with Dr. Kalra, and we're doing a AAA, and I said, okay, so this patient comes in to my critical access hospital in extremis. What am I going to do? And then we walked through, how I was going to do my incision, how I was going to get my superceliac clamp on, and everything. Now today, 4 years out, I don't know I don't know what I would do. I probably would do everything I could in the ER and not take that patient to the OR in my hospital, given my limitations that I know about. And Ben, if you find yourself in some freaky situation in the next couple of years, call my cell phone. If if you're driving into the ER and it's some crazy situation and you want to know like what I would do, and it may be different because you told me you have 2 ICU beds, you have MD anesthesia. There's some differences and you have to make your own decisions. But you don't want to use patients as I don't know. I want to be respectful of my patients, I guess, in the stories that I tell. But I can think of at least one case where, I did the right surgical thing, but I don't know if it was the right thing with my surgical limitations. And so you have to think about things such as time is val. What are you doing, with the stabilization? But generally, it's never wrong to get them stabilized in the ER before transport comes. And then you got to decide, there's all the trauma that you're going to see is a big one. But the case I'm specifically thinking of was actually a bowel perforation from strangulated hernia. And when I walked in, the patient was dead. So they were coding and vomiting and aspirating all in front of me. And it's like, how do you handle that? And it's an extremely bad lie for the patient. Try to do everything you can to save them. But how much of that needs to be done right then and there? And of course, there's no flights because, ceiling's low. These are real life situations that, I found myself in, and you may too. And, you have partners, but phone may or may not work, or they may be traveling or whatever. So having some other people that you can call, and just feel free to call me. And I always have my phone on. So I know you won't abuse it and everything. It'll be fine. So that's like background to me getting there that someone may find valuable, and the worst case scenario. But what does 99% of my practice? So when I'm on call at this hospital, first off, there's 2 other surgeons, and I'm on call 1 in 3 for a week at a time, 7 a.m. Monday until 7 a.m. the next week. And I usually get between 2 and 4 consults per week. So often no consults on a day. Most common consult I think I get is a esophageal food impaction by the numbers. Appies and colies are about on par with esophageal food impaction. Strangulated hernia sometimes happens. Doesn't happen as much as I thought it would. And then, there's the smattering of other things. The GI bleeds, small bowel obstructions, those are common things that I get. I also have done several ovarian torsions. Do you have OB at your hospital?
We do, but yeah, it's not always available.
Okay. Are you on call in any way for C-section coverage?
No, they closed our L&D department right around the time of COVID, and the plan is
How far do people have to travel? How far do people have to travel to deliver a baby?
Yeah, it's about 45 miles down the road to Bishop, California. I know but there's always a possibility that someone, especially with weather.
These are all things that anybody in a rural place has to think about, managing your resources. The last thing I want to talk about is thyroids. So I did a parathyroid and managed a couple other questions about thyroid and parathyroid. I got privileges to do adrenals. I did a couple thyroids too. I don't have a nerve monitor. I don't have intraoperative parathyroid hormone monitoring. And so then I talked to endocrine surgery about it. They said, well, you could do a 4-gland exploration. That's what you need to do, or else IOPTH. Those are your options. But I had then talked to some other rural surgeons, and they said, yeah, that's true. But if your resources are such, do you really want to do a 4-gland exploration when you have a localized adenoma? So I took out a localized adenoma. Patient did well without doing a 4-gland exploration. But at the end of the day, when those cases came up, when a hiatal hernia is on my schedule, I'm excited. When a right colectomy is on my schedule, I'm excited. When the thyroids came up, I was just uncomfortable, And I did 50 on D's service in 6 weeks. It's not that I hadn't done them. It's just, you will know in your hands, you want to just do things that you just know you're the guy that needs to do that case. And breast is like that, for me. And so, I have decided not to do thyroids and parathyroids, and definitely I wouldn't do an adrenal right now. But in the future, if I get a partner or a group and we kind of grow and I have somebody that has a specific interest, I'd love to scrub with them. And then maybe we try to grow that service line. But I've had other things that I've been trying to grow. And so,
Yeah. So when you went into some of these other smaller hospitals that you said you're working with that hadn't done as much general surgery in the last year or two, how did you go about ordering equipment, getting them to get you new stuff? I've come in and some stuff hasn't been done. They haven't been doing a lot of laparoscopic surgery in general here for the last couple of years, and there's not the mesh that I need, not the tackers I need. I'm having to even look up actual order and stock numbers to try to find things. And it's way different than training. You just sort of showed up at a case at Mayo and everything was there. I guess one piece of advice I would encourage people to take pictures of all the equipment that they're using in training if they're going to go out to a smaller place, because it's really nice to have those on your phone and be able to show, your supply folks what you mean.
If you're in training, you want to print out op notes and put them in a binder or save them on a disk. That would be a helpful thing to do. And then also, like you said, the equipment that you're using, take a picture or write it down so that you kind of know. And then when you leave residency, take as many preference cards as you can with you. And then keep good contacts back at your residency. Don't burn all the bridges on your way out. I love doing that. But at least I had enough buddies that are still left in residency, and I was so burnt out by the end of it. But for example, I called Heller for the. I didn't call her. I called just called the office in the surgery area and then talked to the charge nurse and then got through to the techs that way to get that tumescent mixture for the skin graft, split thickness skin graft, things like that I should have probably done when I was a chief resident. I didn't think about it until I had my first skin graft I needed to do. And I was like, oh, what's the mix, So you have to do that stuff. I want to talk about two other things. One is urology. Do you have a urologist at your hospital?
We do, but one of them's retiring here in about a month. He and I are going to do a case together before he retires, and then the other one I think is sort of on his way out too. So, but they're not consistently up here.
Is the case a combined general urology thing, or what's the case?
Yeah, so it's a low midline hernia after a hysterectomy, and there's a little bit of bladder that looks like it's a budding, maybe coming into the hernia sac. So I just want him around for backup in case there's any issues.
Okay. Well, I was kind of asked by the hospital that I was going to, because I said, here's the rural surgery track. I have special training in OBGYN, urology, ENT, plastics, ortho. I had rotations in all those things in residency. What are you currently sending out of your ER regularly that I could come in and help, like add a service line to your hospital, because whether or not you need 3 surgeons. And that's the problem is most places, they don't need a full-time urologist, OBGYN, whatever. They need like a 0.1 OBGYN, a 0.1 urologist. And if you can have a general surgeon that can do a lot of the chip shot, easy stuff, like hysterectomy, tubal ligation, vasectomy, carpal tunnel, and I do all those things. That is easily within your scope as a general surgeon, technically, if you just have a little bit of training. That to me is like rural surgery is one way to define it. But I went back, they said kidney stones. So I do common bile duct exploration using the LithoVue ureteroscope, disposable ureteroscope. One thing I really like about this, if I break it, it doesn't matter because it's disposable anyway. Whereas your regular ureteroscope costs, $100,000 or whatever. So you're really being careful with it. It's the same exact piece of equipment that I use to scope the bile duct. Flexible ureteroscopy is like exactly the same, technically less demanding than that. And there's also judgment, so what are you going to do? Like laser a stone way up in the kidney that you have to really retroflex to get at, you just have to know. But the majority of it is a ureteral stone that is just too big to pass and they fail a trial passage, and it's really not that hard. And that would be a huge value to my community if I could do that. So I went back and I did some ureteroscopy towards the end of training in the middle of COVID, like with the urology guys. And then I came out to my hospital and it became very political and weird. I don't really know exactly all of the details and why and everything, but the same people that were asking me to do it were then making a big deal and it was like an ego. I mean, it was a whole thing. So I end up going down to Indy, shadowing for 3 days with a urologist that he specialized in kidney stones. We did like 18 cases together. He agreed to retroactively review my cases by video and chart review. And I had it all kind of set up to be able to proctor, but then the hospital ended up saying their excuse was, we can't do it because we don't have anybody currently privileged to do it. And so we don't really have a way to, we don't want to do this way that you suggested. And so we don't want you to do it. So I wasted all this time and what do I care? I mean, good grief. I was just trying to sincerely help. And, that's how that ended up. It made me feel like when I was going to buy my house, after residency, I bought an $83,000 house in my hometown and set myself up for success in so many ways by doing that. But I called a bank to say, hey, I got this house under contract. And I heard about this thing called physician loans where you can get no money down, but no PMI, mortgage insurance. And, oh, yeah, we'd love to do that for you. We could give you this house for We'd love to lend up to $750,000. And no money down, no PMI. If you want to buy up to $1.5 million, we'll lend 5% down, no PMI. I'm like, okay, great. So I got this house under contract for $83,000. So you should be able to do that. No problem. Oh, well, wait a minute. Actually, we're gonna have to get back to you. So then they call me back. Well, you're actually 4 months out of starting your new job, and our policy is we don't do these physician loans unless it's 3 months or less out from starting your new job. I'm like, all right, fine. I'll just put 20% down. We'll just do a regular standard job. And you can just use because they're like, we can't use your future earnings on this. You have to, I was like, well, you could just use my current earnings as a resident then, and I'll just do a regular loan. Well, actually, you told us that job is ending, so we can't use your income from that job either. That's like how it was. So I called my regular bank up that I owned an apartment with in Minnesota, and I was like, hey, we're going to just do 20. And I almost just put the cash down for buy the whole house. It's like such a joke. But you find yourself in these frustrating situations, and you want to try to have humor and not get as upset as I do sometimes. And let's move on to the how I do it section of the show. Ben wants to talk about, or I like him to talk about, inguinal hernia laparoscopic approach. So there's a couple of approaches. So guy walks in with an inguinal hernia in your clinic, Ben. What are the pre-op things that you're thinking about? And when do you decide laparoscopic versus open?
Yeah, so I think, my default is probably lap. I trained with a few people that did it almost exclusively lap, and then one guy that did them always open. The sort of conversation that I like to have with people is that, there's some evidence that there's probably, less chronic pain with lap surgery. Theoretically, those incisions are farther away from the mesh, so maybe there's a little less of a risk of, a mesh infection if there's any sort of surgical site infection. And then I think the biggest thing that I like to think about is if there's any question of there being a hernia on the contralateral side, you get a nice view of that. And I don't know how it is in your practice, but most people I know aren't routinely opening up the inguinal floor as well too. So you get that coverage of those other spaces, the femoral and obturator with the mesh, which I really like. Women, I'm almost always going to offer them a lap approach, just because there's that concern that it could be ephemeral, even if you don't think so on your exam. I don't routinely get ultrasounds. Sometimes they come with an ultrasound if they saw a primary care doc. If they have a previous CT, it's always nice to have. I guess times when I wouldn't offer lap, if it's a really big, inguinal scrotal, they're just painful. Lap, I think better open. And then, obviously if there's some medical contraindications, if they're not going to tolerate laparoscopic surgery. But yeah, my default's sort of lap at this point.
Yeah, so I have a couple thoughts on that before we get too far into it. There's some new data out there. Recommendation, was it SAGES? I cannot remember. Don't hold me to this. I saw some guidelines, though, that were women do it lap. That was a new thing, like within the last couple of years. Shortly after that, I had a patient come in who had vertical midline incision multiple times for crazy things and had issues and perforation and go back, repair this or that thing. Okay. I smartly quoted this new data and decided to do her lap. And that was a mistake. And so all the rules are made to be broken, and common sense trumps everything, right? And I'll tell you in my practice, what I do is if I have a man with a unilateral inguinal hernia, I do it open. And then if I have recurrence after an open, or if I have a bilateral, then I do lap. And I definitely think those are your things that you definitely hang your hat on. Now for women, same deal. I would do it lap. Anybody that I do lap, I also consent them and pre-cert them for possible contralateral repair, so that's taken care of. I agree, if it's a scrotal hernia, then I will always do that open, even if it was a recurrent after open. It's just too hard. But don't forget about those contraindications: that prior radical prostatectomy, the lower midline incision, multiple previous pelvic surgeries. That lady did not do well. So it was a very, very difficult case. And I don't know how much I'm supposed to, maybe I should probably talk to a lawyer or whatever about, what all I talk to, but this lady's like my neighbor, and it's my practice. And, I don't think I did anything. I didn't breach duty, but there were damages. So the patient ended up having a delayed bowel injury and came back, and I got the hernia fixed, but, that was one of my worst things that's happened, and it was not necessary. If I would have made, it was like a little marble sized at the external ring hernia, I could have just went straight down there. It was clearly not a femoral on exam. It was plenty high. I could have put a little patch in and out, and everything would have been great. And so those are the things. Now you're going to have some stories like that. Maybe you won't share them on a public podcast in 4 years, but hey, it's humility. So.
No, you're right. Those
are the things you're thinking about.
Yeah, those previous pelvis surgeries. I mean, I remember getting talked into one in training when we had our chief clinic and did a guy with a, previous robotic prostatectomy, and those aren't fun. Those aren't fun cases to do lap, even if you have one of the best lap surgeons, probably in the country, sitting next to you saying that this is the right thing to do. So I'm not doing. Yeah, you're right. I'm not doing any of those. Any multiple pelvic surgery sort of things. So that's open.
Yeah. So great. So we'll say you got a guy that it's inguinal hernia, just one side, but you decide to go laparoscopic, and because of all the things that you just mentioned. And so how do you say we'll skip ahead from the pre-op clearance as a person? He's good for general anesthesia and everything. He comes to the operating room. How do you position him?
Mm-hmm. Yeah. So, I tuck both arms. I tell anesthesia that they're going to need to give me a little bit of extra room at the head of the bed, keep the drapes low. Once we get to that point, he's going to be in a good bit of reverse Trendelenburg. So I'm making sure I've got him really well strapped to Trendelenburg. He's, really well strapped to the bed. And then
chest strap, leg strap,
both. I'm doing both. Yeah.
You prep the scrotum in?
I do. Yep. I do prep the scrotum in. And then, I also ask that they don't have an upper bear hugger. I think that's another thing, that just, some blankets up there are fine, but that can get in your way.
Okay. So then your drapes go from where to where?
Yeah. So we just have a standard, laparotomy drape. I usually have to, cut it a little bit to make it wide enough. I keep the whole abdomen exposed. I know some people in training would just sort of drape out sort of the mid abdomen, sort of periumbilical region. I got blue towels down in the groins, and sort of all the way around on all four sides. And then that top drape, I think one of the key things is that it just needs to be low and out of the way of your elbows and while you're operating.
Where do you put your ports? What kind of ports do you use?
Yeah, so I do 2 5s and a 10 is my typical. So the 5 I'm doing initially to get in. So I make a supraumbilical curvilinear incision, cut down to the umbilical stalk. If they've had no previous surgeries or nothing in that area, lifting up on the umbilical stalk, sort of right at the base, there's always that nice little sort of soft spot almost that you can get in. And then get in, and then I go in with a naked 5. So I take the obturator out, put the 5 in, take a look with the camera real quick, make sure I'm in, insufflate. And then if I'm doing one side, I'm sort of offsetting my ports a little bit. So the opposite, so the contralateral side is slightly lower and the ipsilateral port is slightly higher, but sort of both kind of centered around that umbilical port, hand length.
Okay, so you're not going in optical with that 5.
No, it's essentially a cut down with a 5, and then going in just with we just call it, a naked 5 without the obturator, and then just checking to make sure you're intra-abdominally before you blow it up, because if you don't, then your peritoneum's got a bunch of gas in it, and it makes the surgery less fun.
I see. So there's very little risk of injury to bowel because you don't have the obturator in your 5.
Yeah, and you still have that, either a coker or a penetrating towel clamp on the umbilical stock holding it up while you're going, and you're pointing down towards the towards the like bladder and stuff, not at the bladder obviously, but you're sort of away from any of the vessels.
It can be hard multiple ways because it can go then preperitoneal. That's the one problem. But if you go straight back and you point straight towards the aortic bifurcation.
Yeah, I'm not big on that.
So where do you put a radially dilating 10 in then? That's you bring your mesh in through?
Yep, exactly. So what I'll do then is I'll put one of the 5s on one side or the other 5 that I'm using, and then I'll exchange the 5 that I previously placed at the umbo for the 10. So I'm not opening up any additional ports, and then I'm putting that other 5 on the other side.
Before I forget, on the way out, are you putting a stitch in that fascia at the 10 site then?
Yeah.
But the other ones are not?
Correct.
And it's just a vicryl stitch?
Yeah, I mean, I got kind of more comfortable using PDS, but on like a CT2, but the vicryl on EUR6 is pretty nice. It gives you,
something like an O.
Yeah, exactly.
Okay. So then you got all set up. Now you're kind of centered around the one side. I can imagine on the contralateral side is a little bit lower towards the pelvis. I have gotten into trouble just to say the lessons learned, putting those 5s too low.
Yep.
Because then I get into the place where I want my flap to go. So if anything, they're at the level of the umbilicus for me or above.
Yeah, exactly.
I actually go in with a Hassan 10 at the belly button.
Yeah.
But same difference.
Yeah.
And I was using an 8 trying to be cute there. And then I just couldn't get the mesh through all the time. So I decided to forget it and make it easy for myself. So I used the 10-12. But anyway, go on. So now you're looking and you see everything's contents are all reduced and you just got a nice, cute little indirect hernia there.
Yeah. So camera's on the same side of the hernia for me. And then I've got usually scissors, laparoscopic scissors on the contralateral port. And then I've got a Maryland to start through that 10. And then I'm just pulling. I mark out probably about 5 centimeters above the defect. Gauging it with the width of the Maryland open, and then I'm pulling down on the median umbilical ligament, cutting that with cautery, and then usually you can just run your hand, kind of like you're cutting up some like wrapping paper, sort of towards the ASIS. Usually have my assistant pushing on the ASIS to give me that landmark. And then once you have that peritoneal flap edge sort of developed, there's usually a little bit of, a combination of sharp and electric cautery to sort of get things started. And then just some good traction with that Maryland. And then sometimes I'll even switch it out to a soft bowel and just do some spreading to open up that flap. There's that sort of spot.
Like a fenestrated retractor with a little pad or a hole in it?
Yeah, sometimes, or just like, the standard, sort of like soft bowel laparoscopic grasp where I just
I've got those ones that got a hole in it. I really like it. But
yeah. No, I know what you're talking about. Yeah. And so you just, open and spread. Oftentimes there's that area where the sort of the transversalis sort of comes up over kind of by the bladder, and you have to find that transition zone and get through it. But then, really probably the biggest thing I've found that was super helpful was leaning on the bladder, and in that medial sort of dissection, you can do a lot of that bluntly. You can do it pretty quickly, and you can get that tunnel sort of down to Cooper's. Pretty nicely. Yeah.
Some people listen to audio and maybe not video, so they don't see my move there. But
it's that nice, medial traction against the bladder. You're gonna be safe.
But fully in the bladder?
Not so bilaterals for sure. If they voided right before the case for a unilateral, not always.
Yeah, I would agree with that. Okay.
And then,
so what are some tricks that if it's a little bigger and it's really far down there?
Yeah.
I've heard people leaving sac behind. I hate that idea, but sometimes maybe you have to. I don't know. Tell me some tricks.
Yeah, I think so. Then once I have sort of the big dissection, and then go lateral and work that area down. And sort of you get, just like they talk about in sort of umbilical hernia surgery, you get that volcano sign sort of thing. So you can see the sac going in. I like to use 2 Marylands, and I put heat on one of them, and then it's sort of just, one of them's buzzing and to sort of pinch and separate. And it just kind of becomes sort of a little bit tedious, but you're sort of working circumferentially around that hernia and sort of inching it along, if you will, and pulling those, those little sort of bands and stuff apart with a little bit of cautery and some traction. For the most part, I think it works pretty well. Sometimes you have to add that extra port. I've only had to do that once or twice, and probably people that I should have done it in open. But yeah, I think it gets a little tight to add an extra one to help someone retract with. Usually put it on the ipsilateral side, sort of above where my other 2 ports are, and they're just putting a grasper down there to sort of help retract.
Mm-hmm. All right. So you say you get the hernia sac completely reduced. Say you made a hole in the sac.
Yeah.
How do you manage that?
Well, I think the biggest thing is in training, make your or have your attendings make you a suture down there, because it's weird angles. If it's a really small hole, just a figure of 8, like 3/0 vicryl. I've done that. Sometimes if it's really tough angle and you just really can't get it, I think there's no shame in just using a surgical clip to close that peritoneum, like a 5mm clip applier. Bigger ones, that's when I start thinking about like a 3/0 V-lock. And then, to close.
We have those now at your place?
We're working on ordering them, so that's part of the ask.
So that's like a PDS 3/0 V-lock.
Yeah,
right?
Yeah. The 6 and 9 inch I think are both really helpful to have.
You have a needle driver there?
We do, yeah. So we it's like the Castro style ones. That's what I was most comfortable with. There's also like those like more like, I don't know, I call them pistol grip style. Those I think work pretty well. And then sometimes the OB have like these really big handled ones. I feel like those don't close as well, because you want something that's gonna.
They're all stainless, right?
Yeah.
Then the last segment, resources for the busy rural surgeon. So in your 2 months, what are the essential resources that you're using regularly?
Yeah. I think going back to what you said about having those mentors that you keep in touch with from residency, I think that's a huge resource, especially early on. Running stuff by them like, hey, am I crazy to do this here? My capabilities. Here's the capability for the hospital, that sort of thing. And then I think, your partners, obviously, if you have them, and then, stuff like this, like what you're doing, and then, I'll always say a plug for, UpToDate. I think it's no shame going out there and checking that. If you have to negotiate that into your contract, or, you have to end up paying for it yourself and you can write it off, sort of thing. I think it's a smart resource to have.
Nice thing about UpToDate is it tracks your hours and it gives you your CME, and it's simple. You're really doing the work, so that's a nice way to do it. I love it. Hey, anybody that I know from Mayo that you've been calling?
I'm trying to think. No, last year we had to call Heller for a few things for some nasty EC fistulas, but no, mostly some Phoenix people. So
I understand. Yeah. Hey, I would tell you one thing, Ben, and this is going to get repetitive for people that are listening to the podcast, if there is anyone. But there is a group called the North American Rural Surgical Society now, and they meet every Martin Luther King weekend in January at the Brown Palace in Denver. And that is it's only on Saturday, like an 8-hour or so CME thing. They have a dinner the night before, a dinner the night of, so we can all kind of develop relationships, people that you just click with and you can text. But every topic is relevant to my practice because we're all doing the same thing, and it's different than so if you go to American College of Surgeons and you're trying to listen, and it's like, okay, we're talking about we're going to give whole blood now in our trauma protocol, and it's like, okay,
we don't even play.
You lost me. This is our esophageal cancer protocol or whatever.
Yeah.
Like, there's rural stuff within the American College of Surgeons. I think everybody should be part of it. All of our rural surgeons for sure should be part of American College of Surgeons. But North American that's for us.
Yeah.
So
that's awesome.
Maybe I'll see you there.
Yeah.
All right. Well, thank you so much for joining everybody that's been listening. This has been the Rural American Surgery Podcast with Dr. Mundell. I will see you next time. Please don't forget to share this with all the rural surgeons in your life. Like, subscribe, do all that stuff. Interact with us online. Thanks for being here. I appreciate you. Keep up the good work.
Thanks.